Morning, everyone. Thanks for being here. We have my normal class and a lot of extra guests here. Really excited for today's presentation. I'm going to let Dr. Kate Pounders from the School of Advertising introduce this lecture and our speaker.
Hi, good morning, everybody. Thank you so much for being here. We are really honored today to have our distinguished speaker for the Jerome Williams Distinguished Speaker Series, Dr. May Lwin. And she is the Associate Provost for Faculty Affairs at Nanyang Technological University in Singapore. So she came a long way to speak to you all. And she is the President's Chair of she's the President's Chair Professor of Communication Studies at the Wee Kim Wee School of Communication Information. And she studies and does research on strategic health communication. So she is a perfect fit for today's class. So let's give her a warm welcome. Thank you.
Thank you. Thank you. Testing. Is this working? Can you hear me? Okay. Thank you very much to Kate and to the Moody School and UT Austin for inviting me here. And I'm so happy and honored to be here today to be the Jerome Williams speaker for today's lecture. And I'm also very happy to have a big group of Nanyang Technological University students and faculty, including the chair of the school, Jack Chu, and Pei Wen, who is leading the team. And I'm also very pleased to have the honor of Lillian Williams being here today. And of course, thanks so much to Mimi Dramright, Kate, and Mike, of course, for hosting me in the class this morning. This lecture, which is really going to be about my work in the past couple of years, especially during the pandemic, is dedicated to the late Professor Jerome Williams. And I'll share with you a little bit about him and my association with him. If you Google Jerome Williams, I know that there are a lot of first year and new students here. Professor Jerome Williams was an icon of this university and of our communication and also marketing studies in the business school. He spent many years in UT Austin, and also and when he retired, he was the provost at Rutgers University, and he had impacted so many of us in so many different ways. And let me just share with you a little bit about Jerome. I first met him when I was a PhD student. And like many PhD students, I was helping in one of the conferences. It was a communication conference, and he had come to Singapore. And he was an esteemed professor, and I was a student. And like all students, we try to talk to all these well-known professors and create connections. And we realized that we have mutual interests in common. And Jerome, he was like no other. He was so helpful. He kept in touch. He was interested in my research. And over time, he became a mentor and a friend. And I do miss him. And, I know that he would have been so proud of some of the work that many of his colleagues in Asia have done. And I wanted to share that with you today. Many American faculty and students don't know about Jerome's work in Asia, but Jerome traversed both the United States. So he was initially, before UT Austin, he was at Penn. So he was in, of course, Philadelphia and Austin. And you can see this is the 30-hour flight that the students took and I took across. And he spent some time in Hong Kong, but particularly Singapore. And in Singapore, he was the visiting professor at National University of Singapore. That's my alma mater, and also had different types of appointments in China, in India, and different places. But two particular episodes are really significant to me. One was that he hosted my UT Austin visitorship in 2007-8 when I was doing field work. So I was here, and I remember, all those places that Jerome took me to, this school, the people that I met, the friendships and the relationships that we made with UT Austin, which has enabled such good collaborations between Nanyang Technological University and UT Austin today. So if you are coming to visit Asia, remember, come to the Wee Kim Wee School, look out for us, okay? You've got a lot of friends now in Singapore, and that's because of the roots that go back to Jerome's efforts. And then he was a Wee Kim Wee professor, so we've got this visiting professorship. So he was in NTU twice as a Wee Kim Wee professor as well. And so that helped to cement many of the relationships as well. And I've added this term, and because of his he never complained about the 30-hour journey. He took it like he was going to Houston. He would just come over and he would, come and mentor students. He would come and do research, and sometimes 3-4 times to Singapore in a particular year. And because of that kind of, interactions that he had, he really was conceptualizing what was global, but every time he was in a particular place, and you see this in his research, he really wanted to see the impact in the local or the national space as well. And that is something that I have taken away from Jerome. Oops. And just wanted to share with you some personal memories as well. So when I was at my sabbatical at UPenn, and Jerome and Lillian, they hosted me again. In 2017, when my mom was ill, she was in the hospital, Jerome and Lillian flew all the way to come and visit. And this meant a whole lot to her, and I'm very, very grateful. And in 2013, Jerome saw my children literally from toddlerhood to to the young women that they've become today. And in 2010, at the ICA annual conference, which was hosted in Singapore, Jerome was one of the keynote and plenary speakers, and you can see him there with a lot of the health communications scholars as well. So some personal memories there. And of course, today I want to talk about research and Jerome's impact on my own research and health communication. And we, have kind of like similar backgrounds. We've got this very eclectic background. Jerome had English background, and he also had business school background, and he was particularly interested in health and societal issues. And I've also got a business school background with liberal arts, and so that mix into communication, and I teach advertising and promotional communication. So we were interested, but we were interested in particular types of issues that would bring good to society. So we were early researchers who looked at consumer online privacy concerns, and in that space, we use something called a power equilibrium responsibility model, which really talked about large organizations having the responsibility to consumers and customers as well. And we were one of the earliest scholars in health communication who looked at different types of Western theories and concepts, and to understand whether they would be applicable in other countries and other cultures. And one of the earliest works that we did was on organ donation, and we looked at this very well-known theory in organ donation called Horton and Horton's theory of organ donation. And we realized that in Asia, a place where there was a lot of superstition and fatalism, that a theory like that was grounded on cognitive knowledge could not be applied fully. So that was a paper that we published in Journal of Public Policy and Marketing. And then we had done a whole bunch of work on consumption and childhood obesity. Jerome was serving on one of Michelle Obama's task force, and he was very passionate about childhood obesity and that link to marketing communication. And of course, we did a lot of studies that were intercultural, looking at the issues across different cultures as well. And that one of the papers that we're particularly proud of was in Journal of Communication 2010, and it was about an animosity ethnocentrism perspective about how people in different countries looked at American symbolism. and how that was really linked to different facets of cultural identity and so on. So it was an eclectic mix. Jerome never said that, just focus on this particular area because you're a young scholar, that's what you should be focusing on. He was always enthusiastic, always very nurturing, and always very helpful in giving me the American perspectives. So I'd like to start off my portion of my research by sharing something that Jerome wrote in one of his papers, and that the importance of transformative service research, making sure that your research transforms to real-life applications. And he says that this is a call for service research that relates to and advocates for personal and collective well-being of consumers, and more broadly, citizens and the entire global ecosystem. And he goes on to talk about, how we need to build environmental systems through respectful, collaborative, and sustainable interactions. It's kind of encapsulates, his approach and how he also embedded these research ethos into my own research. So I summarize 3 kind of simple takeaways that Jerome left with me in terms of lessons. First is the global impact and the local impact that I mentioned to you. Second is doing good through transformative social and collective action. And the third part would be just about education, mentorship, this kind of nurturing spirit that he always had. So please let me talk about what I mean by global lessons and local impact in one of my research. And this is, of course, pandemic communication. So this is NTU from the air. And you can see that on the top right-hand corner, that is the where the students live. So we have student dormitory. Some of the students here will be familiar. And on 28th January 2020, a day that I will remember forever because it is the second day of Chinese New Year. So just like Christmas, nobody works and nobody ever contacts you from the school, but we receive a call, and I saw that it's from the university. And I knew that it's not good once a university calls. So what they did was they said that the pandemic is at our doorstep. All the students have to leave the dormitories now. And of course, everybody was away. Some were back in their home countries. And so when they said, no, there's no excuses, we're going to call the movers, and all the bags are going to be put outside, and the students have to come and remove it. And if they weren't in the country, they've got to get someone to remove the things. And so we knew that this was something serious. And of course, indeed, it went on to impact us for the next 2 to 3 years. But for me, as a health communication and communication disease scholar, this was also the start of my research. And immediately we sprang into action. I was very lucky that the Singapore government had enabled COVID funds to be used to do research at this time. So I had done these different packages of research, COVID and the media, social media in particular, the social media and vaccines, medical misinformation. This evolved over time into medical misinformation. And then, something that really I would say Jerome had always inspired, which is not just to look at the majority populations, but to look at the vulnerable and the marginalized groups. I'm sorry, I'm talking a little bit fast because I've got so much to cover, and I know some of you have to go off at 10:45. So please, if you have to leave, at 10:45, I won't be sad. You can, no, I'll miss you. But if you need to talk to me tomorrow, please catch up with me. I think I've got 2 more talks to students tomorrow at the undergraduate class and the PhDs. So I'll be happy to answer when you leave a little bit later, okay? In the post-COVID environment, going back to this, I've continued to do a little bit of work in the COVID space, particularly looking at vaccine hesitancy, especially in Asia, and then looking at communities that are living with long COVID as well across different countries as well. So please let me share with you what I found from the first package, which is the social media. I'm sure that you remember receiving a lot of texts during those days, a lot of texts, a lot of social media. And for the first time, it would have been on health rather than about your social activities or politics and so on. So in those days, the increase in the amount of messages about COVID was unprecedented. So much so that the WHO, for the first time, called something that was not a bug, but it was information, a type of virus. And they coined the term infodemic, and they called it 2019 nCoV infodemic, just like it was a disease, to talk about information. And so this was very well recognized. And I had been doing research on how different types of messaging about pandemics and about outbreaks comes into being on social media. Remember 2017, 2018, this was just happening. And if you also remember, we had things like Zika and Ebola, right? So when we had the Zika outbreak in Singapore, I was tracking on the top the government posts on Facebook. Okay, remember those days when people were using Facebook and they were using Twitter? So we tracked that, and you can see that it really paralleled messages like what WHO did. So in this little line, you can see that there's a little bump, so people talked about that. And then when Singapore had the first imported case, people talked about that. And what happens is that on the top, the blue line, are the government posts. The government or the health authorities posting this information. And we also have the first cluster in Singapore. And at the bottom were what the public posted. So you've got the Twitter conversations, the Facebook conversations, right? And what you would notice is that the two are almost the same. So people took what the health authorities were posting, and then they shared with their communities, telling them to be careful, to make sure that you wear masks, etc. Now let's fast forward to COVID. What the government was posting out in terms of traditional news media, which is the tool that government uses in Singapore for health messaging, is in blue. The conversations on Facebook and Twitter are in orange and in yellow. So you've got official information that is here, and sometimes as many as 5 or 6 times the amount of conversation that was occurring about COVID-19 that came from who knows where. And that created that infodemic situation. So a lot of information was coming out. Nobody knew if this was from the authentic sources, etc. So this was a big, what we call the gap that existed in that particular space. And right at the bottom, you can see the references. We studied this. In fact, this whole exercise, in this whole exercise, we collected about 80 million conversations and discourse. So that was the combination of that big data analytics. And so if you would like more details, it's in those publications. And what was concerning even then was that a lot of information that was coming out was untrue. And it created a lot of public confusion. So for instance, just in all schools, including polytechnic and universities in Singapore, to close from Monday onwards. So this was going around in the university circles, right? And students thought they don't have to come to school and so on. And you can see that this happened across distribution channels. It happened across the medical community, healthcare community, also was in content. And so what we were realizing is that gap was filled with a lot of untrue information, which was very unusual. Very unusual because for communication scholars who were studying misinformation, especially before COVID, misinformation was something that was prevalent in politics, international relations. It rarely occurred in health and science, where we always believe that there's authentic materials that we can reference and so on. But it was happening in the health space. Even doctors were putting out information that was less than true. So, so we looked in this particular paper, we looked at the disinformation, the very strong misinformation that was coming out in Singapore. And we were finding that really about 38% of the misinformation was in medical and healthcare space. Also, another 16 plus 6% on government policy and measures in Singapore. And that was related to COVID. So this more than 50% was related to health. And then you have other types of misinformation. So this was really startling to everybody in the health community. And when we dove in and looked at the types of misinformation, it wasn't as intentional as what you would see in political communication space, where the purpose is typically to try to persuade the audience to a certain course of action. It was sometimes done in a joking manner, or it was done in a way that was meant to help, like, ginger is good for you, and then by the time it passes to many different users, it becomes ginger is good for COVID-19, that sort of thing. So won't go into these details, but I think many students who are studying the misinformation would know that there are all these categories, and they kind of tended to be very dispersed, but it was there nevertheless. So what we wanted to do was we wanted to see, well, you have all this information, what is really, what is this information really impacting in the population space, right? So in order to do that, we can't just look at the misinformation and the effects. We needed to see how it was shaping the population. And we wanted to look at the emotions or the sentiments that this was creating amongst the population. So this is what we would call, what people express is just on the top of the iceberg, but there could be so much more that's happening, and we needed to uncover that. So to that end, I worked with my colleagues in an institute called A-Star in Singapore, where they do a lot of big data analytics, and they had just recently done some very exciting work on sentiment analysis, which is trying to understand the population sentiments. Now, I think some of you from the communication schools, you might be familiar with using tools like Meltwater that tell you it's positive or negative, and so on. That's in the marketing world, that's very common. But this goes beyond that, and it has 5 dimensions. So basically, like all the discourse on social media, have been coded, and then it can actually tell you based on the algorithms whether the information brings anger, fear, sadness, joy, etc. So what we did was those 80 million data points, we put it into crystal field, and in the very early days, this is what we got, and it was one of the earliest papers on COVID-19 on social media published in JAMIA Public Health and Surveillance, and we've got a lot of interest globally based on this. Basically, if you look at the start of the pandemic, remember that January, February days, you had a lot of fear in the global population. So this is global. We put all the English language, so the caveat is it's in English language, sentiments across the world, and we were getting a lot of fear. Now, for health communication scholars, you know that fear is sometimes pretty good because then it gets the population to act in a certain way. So if people are fearful and you say, don't go out, they won't go out, right? So that was the situation in the early days. And then you've also got the red line, which is anger that was rising across the world population. And when we published the paper on we cut off on 9th of April, we predicted that anger would surpass fear. We didn't know if it would, but it was the trend. And you could see that, and fear was reducing. And so, as we expected after that, we continued to track, and indeed, in many countries, anger overtook fear. Now, look at this situation. If you have a lot of angry members of the public, they are less likely to follow what you ask them to do, get vaccinated, and so on. They would question, and they would, listen to, other sources more than fear. So the more anger you have in a particular population, the more chaotic your health messaging response is going to be. Now, we were happy that we saw a little yellow line that was creeping up. So it's not really joy as being happy, but it was a hope, inspiration, gratitude to the healthcare workers. These were all encapsulated in the positive response. So there was that as well. Now, we said, well, we have this 80 million, and the Singapore government wanted to know, what about Singapore? We want to know Singapore. This is what's happening across the world. And so we looked particularly at Singapore, and you could see that Singapore's situation is not so bad. So many researchers and early researchers who published in outlets like Lancet recognized that Singapore did a pretty good job in tackling COVID-19, and it's become one of the case examples of good governance and response. So when we looked at Singapore, we were grateful that the yellow line was quite strong, and there was also quite consistent fear, not so much anger. So as you will see later when we talk about the local effects, that had implication on Singapore public's response. We also looked at many other countries, and that included the United States and UK, and there was a lot of anger, unfortunately. And then we also found places like India where there was a lot of positive feelings because there was so much pride that they were producing vaccines and they were able to share it in spite of the difficult situation that India faced in the latter stages of the COVID. So it was different across countries, vastly different. And so, one of the things that in my early part of the talk I talk about is what's the impact on health communication theories and what we've learned. And there is actually a theory that looks at risk amplification and attenuation, which in health communication, we believe that when you have a particular health message because of a particular scare, let's say you've got snakes in the neighborhood, right? And you say, oh, there's snakes and so on. And then 2 months later, you go back with that message. There's actually attenuation. People were like, oh, okay, we've tackled this before. It's not so scary anymore. Right? So this is just a boy who cried wolf type of a model. There's also other theories that talk about when it amplifies. But one thing that we learned in COVID and looking at these numbers is that when faced with a pandemic, this kind of reverses. There was actually amplification rather than attenuation. So remember the waves of COVID? So when you have COVID for the second time, people became more afraid. It's like, but you asked us to take vaccine and you asked us to safe distance and do this and do that. And now this is coming back bigger than ever. And so, a lot of the health communication theories kind of reversed. And we, health communication scholars, really have to look at these and understand and know how to respond in the future. Well, the health authorities like to know what does that mean. Yes, sentiment analysis is all good, but the health authorities asking, what does this mean? What are people really doing on the ground, right? So we looked at, we got many different types of data, and those were kind of good days to be a health communication researcher because people were so collaborative, and we were able to get from Google, from the supermarkets and so on, data to just allow us to understand what was happening. Today, I can hardly get that sort of information, okay? But I got it then, and so you can see we tracked where people were. And I have all this data on where people went and all the different places people would go and so on. And as you would expect, people stayed home more, red line. People went to work less, gray line, that continues to impact our world today. And then you have less retail and recreation, blue line. But if you look at the green line, that's where the interesting thing happens. That's the groceries and pharmacy. They should actually follow the work lines, right? And you should not go out so much. But if you look at this particular chunk in wave 2, people were going to the groceries a lot more than we expected them to. And so we dove into that, and we looked at the research, and we found that there's all sorts of irrational behaviors. Again, this reversed some of what we know in health communication. You listen, and then you stay home, and it's like, okay, we do this, but not this. So we would go to the supermarket, and then there'd be big crowds. We would queue, and we would buy toilet paper. Not in Singapore, well, they should be buying. If you're kind of rational, you should get a lot of home appliances. You should get entertainment systems and so on, make yourself comfortable. But people went and bought mountains and mountains of toilet paper in Singapore, okay, and some parts of Asia. And we linked this to the social media conversations, and then we did research to see what were the origins of that. What were the origins of that misinformation? And there was big community groups sharing about how paper factories that made toilet paper were going to be converted to make masks around the region, and so on. So sometimes this type of, not intentional type of news then becomes social media discourse, and then it has very big negative effects in this particular case. Huge implications for food security and other types of concerns, and we have a lot of learning experiences from that as well. So that was part 1, and all the experiences. I was talking to the Ministry of Health every 2 weeks, giving my report, sharing information. We were also publishing on as well, and that was all, of course, done remotely. Now, in the second phase, there was, and that we had a lot of effort to introduce vaccines in such a way that the populations would be more accepting, right? Different, like first vaccinations. But when it came to children's vaccination, we knew that this was a very contentious space in the whole global environment. In some countries, there was the total reluctance if a child was under 12 and was going to be vaccinated. So we learned from that whole episode in the first stage, and there were many things that were prepared this time in parallel. The first was that the government authorities held regular briefings, not in a single person, but across different ministries. These ministers from Singapore would come together and just give briefings and answer all the questions and concerns that people had. Then there was the medical and scientific community. Doctors were deployed to become ambassadors and to help to communicate about child vaccinations and health. There was traditional media. Remember that I mentioned to you that this is one of the partners of the government in Singapore. We're able to work with traditional media. And so they were also helping. You'll see how that's done. And also even the research platforms were mobilized. So it was a much more concerted effort this round, knowing what we were expecting. So that brings us back to another health communication theory. And that in risk communication, some of the basics are just that people were going to assess the risk. What's the chance that I'm going to be on the boat that sinks versus the one that's going to not sink? Or, and professors always give you these examples, right? That this is how people tackle risk. But then we were finding that based on all the work that we were doing, perhaps there is double risk. Do you find yourself doing that? When you look at a particular piece of news, now you're assessing, is this true or not? Is this real? Before you assess the risk. So it's a double analysis. It's quite hard. It's quite hard for the layperson to think about news in this fashion. Okay, so that's also going on. That makes it a lot more complicated in terms of messaging. And And so all these considerations were taken in to think about how to message to the population in such a way that we would not encounter the same types of barriers as in the adult vaccination space. So the health authorities and the traditional media stepped up the positive posts, and also vigilantes and the health authorities were responding to all types of negative posts, basically. So preparedness on social media happened. And you can see, if you see the narratives on the Straits Times, which is the largest English newspaper, you can see how it was seeded. And students of PR, you'll be very interested in this. You see all the news. Most parents keen to get kids vaccinated against COVID-19. Trend of kids in Singapore getting COVID-19 vaccine should be available from January using social normative theory and so on. So all the seeding went on. And in February, this was launched. A lot of kids in Singapore received the vaccine, and then the news about efficacy was seeded. It worked across different media, and I know that some of you are very good in coming up with health communication campaigns, social media campaigns, and so on, and you have to work across different media platforms. And so the Ministry of Health was putting out posters and different types of messaging to parents, etc. And the Ministry of Education was also doing that in parallel. So for the first time, many ministries came together. The Ministry of Education didn't say, this is a health problem, so you deal with it, Ministry of Health. It was across everyone, even universities included as well. And there was also real policy response. Okay, so that means that, you remember those four gentlemen, the ministers who were sitting together, once they got the information, they had the license to act immediately. So for instance, there was an emergence of COVID in a KTV. There's a place which is popular for KTVs, right? So people were going there to sing and be happy. And within 4 days, all the KTVs were shut down. It's that type of policy response that happened very fast. And so what happened to the whole situation of childhood vaccination? Well, we were tracking. So in NTU, we were tracking, and we found that the discourse, remember that big mountain of infodemic that was happening initially with the adult vaccines and so on? Well, that didn't happen. People were not talking about it so much. And if you look at the social media conversation versus mainstream news coverage, I wouldn't say it's exactly parallel like my Zika study, but it was coming close. It was coming close. We managed to bring down that mountain of infodemic and misinformation. And there was, 99% acceptance of childhood vaccine, and it really helped with the kids and COVID. So this is just to show the Singapore emotion trends also came down overall. So that is the story from COVID and my research in that particular space. Now I have about 10 more minutes, so I'm going to try. So the next part is not going to be as detailed, some of which I'm going to cover a little bit more in tomorrow's lectures, but if you're interested in any part of it, please talk to me and I'll be able to share the info. So second lesson from Jerome is doing good, looking at the vulnerable communities, leaving no one behind. And really this was a situation with migrant workers. I want to show this to you because I don't want students from public health, doing a lot of epidemiological work and health communication to think that you should always use big data, you should have numbers, you should have charts and so on. It can also be qualitative, could also be observation, it could be ethnographic. And in this case of the migrant workers, this is what we did. In Singapore, there's a very, very large pool of migrant workers. They live in very large dormitories, but maybe 6 men to a room in very packed surroundings. And they were impacted severely during COVID. Some of them had lockdowns that lasted 2 months. 2 months. Imagine you've got to stay in the room and not go anywhere. And so, we had a whole program going on with the vulnerable communities. And we really, were interviewing, and our students from Wickham School were involved. They were doing this online. Where possible, when things opened up, they were able to go in person to these communities. And we were really finding that when you have a lockdown and you are stuck in a place for 2 months, the thing that really keeps you sane is that link to the outside world. That is communication. Communication had such a big role to play, and it can help in so many ways. So look at these fronts that we looked at, right? Online communication, what sorts of websites and social media they were going to. We looked at the communication between doctors and the men, because so many doctors, they voluntarily came to be with this community, and they were reachable. You can call them anytime, the kind of form of telemedicine. And see here, a Bangladeshi male migrant worker said that last time if there's a problem, I must inform the employer and then I have to book, and so now I can just call a doctor anytime. That really helped. And they were sometimes asking doctors about COVID-19, not for themselves, but for their families in India or Bangladesh. Right? So that really helped to allay their fears. There was social support that could be galvanized across groups, sometimes with different types of indigenous languages. There was a lot of sharing of news and experiences. And when that is positive, that really helps the community. So ambassadors were identified, and they were given the tools to help others in their community, online communities. And they were very happy to do that. And all sorts of creative ways that the media and social media could be used arose. And this was an online band, right? So they used whatever pots and pans that they could find. They started making music, and it was really very good. So I have this, our students go for a program called Going Overseas for Advanced Reporting. This is our journalism students. So that year, they could not go anywhere. They're used to going to places like Iceland and Berlin and Iran, and they've even gone to North Korea, the students from NTU, but they stayed in Singapore and they worked with these migrant workers. So I'll pass this around. This is a book called Invisible Men, and the work that they did, which was all based on observations and interviews. Thank you. So this has implication on how the government authorities approach vulnerable communities, and I'm so glad that we have been able to help. And this is one of the type of things that Jerome often inspires us to do. So now we are in the post-pandemic landscape. What are some of the things that I am doing? I realized that it was an unprecedented experience for our generations. I hope we will never have to go through this again. But we must take the lessons learned. We must put it into the theories and how we approach what we do. And I'm very grateful that it's given us opportunities for health communication scholars to come to the fore on so many different fronts. The government now realizes that it's important to have health comm experts in their team, and they are shifting the policy towards something called preventative health. So the Ministry of Health should not just be looking after patient care, which is important, but also preventative health, which can have long-term implications as well. And we need to have new scholarly insights. So many of you will be developing new scholarly insights. We have to integrate what's happening on the AI frontier, fake news management, how we look at crisis response, and public health messaging of the future that's going to use a lot of digital media. And we need to be much more collaborative, very much like what Jerome had done, across the world. Really, diseases know no borders, no boundaries. They don't know about this 30-hour flight. So it's important that we collaborate. And I'm happy to say that the school is setting up a new center called Habits. It's going to be the first transformative health behavior and communication center. It's just going to be launched in a couple of weeks. So if you are coming to Singapore, please join us for that launch. I'll look out for it. I continue to use digital media and social media for various types of work. We are looking at empowering people to lead healthier lives, supporting healthcare and caregiving, and then working alongside doctors in identifying various types of health issues. So I'll be sharing some of this again tomorrow, but you can see that we are developing AI generative tools. We are looking at VR. We're looking at different ways new technology will be embedded in these platforms. And here are just some of them. MOBAS is a program that looks at mosquitoes. So we're doing a lot of that in the region because they're a huge carrier of many types of diseases, and so on. We've got other types of programs that are going on. So if you're interested in any of these, I'd be happy to talk to you about them. Vaccine hesitancy continues to be on the rise in my part of the world. If you look at Singapore, Indonesia, Malaysia, India, many people are worried, and we're finding these effects about what happened in COVID now to influenza vaccination, etc. And so, we're trying to do different things, like having a consortium in the region of scholars who are interested in this space and developing different ways that we're going to tackle the disease. Learning that it's not just regional doesn't mean that it's similar. In fact, when we look at the narratives from each of the countries, there are different nuances, different types of religious sensitivities, etc. So this is something that we hope to continue to do. And if you're doing work in any of these countries and you'd like to work alongside us, I urge you to reach out as well. So I have the last lesson, and of course that is on education and mentorship. I talked about all the ways that Jerome has inspired me, and really it's not just myself, but some of my early PhD students like Lwin and Shalini had the experience of getting feedback from him, and indeed for Lwin, he hosted her in UT Austin all those years ago, and she's now an assistant professor at Singapore. Not Southern Methodist University, Singapore Management University. And I have PhD students who have gone on to do work in various parts of the region that continue to transform and really, inspired by many of the works of Jerome. Tomorrow, just a little preview, I'll be talking about participatory surveillance in rural communities in Asia. So look forward to seeing you there. And I just want to kind of end with this slide. We are really at the cusp of what's going to happen with not just humans, but animal health and the environment. I think these areas need to come together more. Singapore is going to host the IMCR, and one of the things we are looking at is One Health. And this is one of the ways that I hope health communication will be able to contribute and to create a better world for the future. So I want to end with Jerome's added legacy. It wasn't just the lessons that he gave in the health communication space, but I always was inspired by Jerome's love for his family, friends, and the community. He always liked to joke that he's a very productive scholar because he had one child every year of his PhD. And of course, now he's got a big brood of grandchildren, and he would really have been so proud of his wonderful family. And he certainly helped to make the world a better place for all. And I miss him terribly. I hope you are looking on and you're proud of all the students here at UT Austin and what we have done. Thank you so much. This is my contact. Thank you.